Today I'm going to talk to you about three main surgeries that we use to treat glaucoma today. I'm not going to cover every surgery, but three of the main surgeries that we use. Selective laser trabeculoplasty, also referred to as SLT, trabeculectomy, and tube shunts, also referred to as glaucoma drainage devices. The goal behind all of our surgeries is to lower intraocular pressure to help slow down or prevent further loss of vision from glaucoma. And currently, this is the only treatment we have available to decrease the risk of disease progression. First, I'm going to talk about selective laser trabeculoplasty. As I said, it's also referred to as SLT. Selective laser trabeculoplasty uses a laser to focus light energy on the internal drainage channel of the eye. And it's designed to improve the function of our drain of our eye, which we also refer to as the angle. This picture that you see here on the right side is an up-close section of the eye in this area. And what I'm showing you here is fluids made in the back of the eye behind, in the back of the eye behind the iris, which is the colored part of your eye. Right back here. It then flows out behind the colored part of your eye, the iris, through the pupil and out to the front part of the eye. This area here where I'm drawing is the angle or the natural drain of the eye. And that's where the laser is focused, and that's where the treatment occurs. Our eye makes fluid to nourish the inside of the eye. This is separate than your tears. And one of the areas that gets affected when you have glaucoma is the drain doesn't work well. Just as if the drain in your sink doesn't work well, causes fluid to build up, causes pressure to build up, same thing happens in your eye. So the goal with this laser is to help stimulate your own body to come in and clean out that drain and stretch open those channels so that the fluid can get out better. When do we usually use selective laser trabeculoplasty? Typically we use it in patients who have early or moderate disease. We can use it as initial therapy. We can use it to try and reduce the amount of drops that someone's already taking. Or if you're having trouble using the drops, you have arthritis or a tremor, we can try and use it in these cases. We can use it if we're on a lot of medications and we need further pressure lowering. So there's a lot of different areas that we can try and use it. Not every type of glaucoma can we use this type of procedure, however. We don't typically use it in patients who have advanced disease with high intraocular pressure. And it won't achieve a low enough pressure that these patients require. When it is effective, we expect it to lower the pressure between 20 and 25%. However, sometimes it can be less or it can be even greater. But that's the average. And when you get the procedure done, we don't really know the full effect till about 4 to 6 weeks after it's done. What do you expect if you actually have this procedure done? Well, it's done in the office typically. You sit at a slit lamp just like you would for a normal eye exam. We give you a numbing drop and a pressure lowering drop prior to the laser. A lens is placed on the eye like you see here. This is designed to help focus the laser and to help keep your eye open during the procedure because you are awake for this. About 80 to 100 applications are applied. You see a flash of light and typically you don't feel any pain with this laser. And it takes about 10 minutes. This is a video, an illustration showing a laser firing in the applications being applied to the drain or the angle of the eye. And again, it's designed to help stimulate your own body to come in and clean out that drain and stretch open those channels. After the laser, your eye is usually washed. Anti-inflammatory drops may or may not be given depending on how much inflammation you have. and the pressure is usually checked an hour afterwards. The reason for this is the biggest risk with this procedure, it's really a very safe and effective procedure, is that the pressure rises afterwards. We actually expect it to rise the day of the laser a few points. However, it can spike anywhere from 20 to 30 points. If this happens, you can be placed on additional medications temporarily to help lower that. It usually only lasts about 3 days, and there's usually no residual effect or damage from that. So what are the benefits? Well, it's extremely safe, and it can decrease the amount of drops that you're already using. We can use it instead of drops. Therefore, you don't have potentially harmful side effects that drops can have. With this procedure, about 80% of patients experience a drop in intraocular pressure for a minimum of 6 to 12 months. 50% maintain an effect after 3 to 5 years, and at 10 years, 30% of people maintain an effect. It can last a few months, and it can last even longer than this, but these are just some average numbers. Additional surgery can be helpful. However, it has a lower success rate and a higher complication rate. So if the initial selective laser trabeculoplasty fails to bring the pressure under proper control, other treatment options should be considered. Next, I'm going to talk about trabeculectomy. This is incisional surgery, conventional cutting surgery where you go to the operating room. And the goal is to create a new pathway for the fluid to leave the eye. We perform this procedure typically in more moderate to advanced disease. When patients have failed, they're on all the drops that we can put them on. They've typically had laser treatment if they could have it, and we need to get additional lowering. Trabeculectomies create a bypass drain, if you will, with your own tissues of your eye. And in a few slides, I'm going to show a brief diagram of how that's performed in the operating room. Like I said, what would you expect if you had this procedure done? It's done in the operating room. The actual procedure takes about 30 to 40 minutes. Sometimes it can be a little less or longer, just depending on the difficulty of the case. There's an anesthesiologist that's monitoring your heart rate and breathing during this surgery, and they give you medicine to make you comfortable and so you don't have any pain. And typically you go home an hour or so after the procedure. So it's typically a same-day surgery, an outpatient surgery. You're typically seen the next day and then every 1 to 2 weeks for the first 4 weeks. And this is very important for the proper success of this surgery. There is an intensive follow-up period. Antibiotic drops are usually given, as well as some anti-inflammatory corticosteroid drops, which are used for a while, usually 4 to 8 weeks after the procedure. Sometimes dilating drops are used, sometimes they're not. Here's the diagram that shows what we actually do in the surgery, just the main points. The top picture I just thought was a better view of the eye and where this is done. It's usually done up on the top part of the eye, which is hidden by your eyelid. And what happens is we make an incision in the skin of the eye, which is called the conjunctiva. It's actually clear, it has blood vessels in it. And then we make another incision, which you see down here. We make an incision in the sclera, which is the white part of the eye. And we make a flap, half the thickness of your eye. And if you can see that over here, that the flap's pulled back. And then underneath that, we actually create a little hole into the front part of the eye. And this is kind of the bypass drain that I'm talking about. Next, we take a little piece of the iris, which is the colored part of your eye, just so that won't clog the drain, that opening there. And then we actually replace the flap. And the reason we've replaced the flap is because if we left that hole open, all the fluid could drain out of the eye and the pressure would go really low. Just as if you let the air out of a balloon, the balloon shrinks, your eye can shrink, and that can cause problems. That's why we want to control the amount of fluid that's coming out of the eye. This also allows us to modify the surgery in the first 4 weeks. Afterwards, we can actually cut some of these stitches to let more fluid out. if it's not as low as we want it. And here's a picture of someone the next day after they have the operation. I'm lifting the lid here, and underneath here you could see this area is the conjunctiva, and it's elevated. We call this the Bleb. You may have heard that terminology. And underneath there is where the fluid's going out. You won't get tearing from this. This is all internal. So these can look different depending on the patient. They can look low like this. It's kind of like a blister. Or it can look elevated like this. Here's two more eyes where, again, this one's low and diffuse. Again, same thing here. It's low and diffuse. And again, this area is typically hidden by your upper lid, so you don't typically see this unless you pull it up. As I mentioned before, the success of trabeculectomy depends not only on the surgery, but on the careful postoperative management. So it's important to follow the instructions of taking the drops and going to the appointments. Because like I said, there's things that we do for the first 4 weeks. That's our window of opportunity to help modify the surgery that we've done in the operating room. Now, in the last 10 years, due to modifications of the technique and changes that we've done, we can get success rates with this procedure as high as 80 to 90%. And we can achieve a very low pressure that we can't really achieve with medications and laser, which people with advanced disease may need. And we can decrease the amount of drops patients use or even get rid of them altogether with this procedure. However, there are risks and complications with any surgery that you undergo. And that's one of the reasons we tend to save this till medications and laser, the things that are easier and have less risk, don't work. Risks include bleeding, infection, swelling in the back of the eye, the front of the eye. The pressure can go too low. You can get double vision or loss of vision. Again, even if you have some of these complications, they can be treated successfully. However, it takes a longer time to heal from the surgery. And last, I want to talk about tube shunts, or glaucoma drainage devices. We usually use these in more complicated glaucoma cases, when prior trabeculectomies have failed, when there's extensive scar tissue, the eye has active inflammation, or they have new blood vessel growth, something we call neovascular glaucoma. Here's an example of what a tube shunt looks like. It's an actual hardware. Instead of using your own tissues of your eye like we do for trabeculectomy, we actually put in some hardware to do the same thing, though, to create a bypass drain. These are what we refer to as plates, all down here, and this is a tube that will go into the front part of the eye and drain that fluid back over this plate. And again, here's a diagram on this side, and on this side's a picture of a patient who's already had that implanted. And what we do is, again, we take down the skin of the eye and we put it underneath that, and then typically we put that plate behind, between the muscles of your eye, which help move the eye. And we do it again, typically under the lids, or sometimes we even put these inferiorly in the lower part of the eye. But again, they're typically covered by the eyelids so you don't see them. So the plate's placed there, and then the tube goes forward and goes into the front part of the eye. If you look at this slide, if you can see here, here's a tube going into the front part of the eye. Fluid goes into that tube, then you can barely see the tube here underneath the skin of the eye, back to over the plate where the fluid goes out. Again, this doesn't create tearing, and we leave these in permanently. This is all internal. This is just a couple more pictures of patients who have had tube shunts put in. Here you can see the tube. There's just material here to reinforce these tubes so they don't expose. And again, another picture here of a tube. The benefits, the risks, and the complications are all very similar to a trabeculectomy. However, they do have some unique risks of their own, which makes them just a little bit riskier than a trabeculectomy. which include tube exposure, obstruction of the tube, that the iris or the colored part of the eye can obstruct it, blood can obstruct it. There's a lot of different things, and it causes it to stop working. The tube can actually move around. Again, these things don't usually happen, but they can. That tube can touch the cornea, which is a clear bubble that covers the eye, and that can cause the cornea can become swollen and cloudy, so it's hard to see out of it. And there's a higher risk of double vision with this procedure. In conclusion, while these procedures work very well to arrest or delay the progression of visual loss caused by glaucoma, they're still only treatments. They're not cures. Even with successful surgery, glaucoma can progress, and further treatment may be necessary. The good thing is we do have a lot of different options that can be done, and a lot of these procedures can be done multiple times. It's really important to continue to monitor your glaucoma even after you have these procedures. Thank you very much.